So we've talked about some diet changes. We've talked about lifestyle changes in the gym to exercise. But what happens now when someone walks into your office, has a history of suspected heart disease or already established heart disease? We hear a lot about aspirin. We see it on TV. There are commercials that are advertising aspirin as a needed supplement or medication. Who should be taking aspirin?
Okay, patients who are considered to be moderate to high risk for heart disease or vascular disease in general should be taking a baby aspirin, 81 milligram low dose aspirin, on a daily basis, unless they've already had a problem of stomach bleeding.
So aspirin indicated for those who have risk factors or who already have disease. What about these drugs we hear about called statins? Medications that can lower cholesterol. Who should be taking a medication called a statin?
It depends on your age and your family history and your level of cholesterol. There have been many publications that give guidelines, and invariably these guidelines, when published, are usually 3 years behind because it takes so long for them to make the guidelines. So you have to figure out what the risk is for the patient. Now, it's not just the level of cholesterol or the low density LDL cholesterol. It's also the whole picture of the patient. There are other factors such as level of inflammation. For instance, patients who have inflammatory disease such as rheumatoid arthritis or psoriasis or psoriatic arthritis have a much higher incidence of cardiovascular disease because of the inflammation. These are the people who must get started at the time they are first diagnosed to really control their cholesterol. In addition to lowering cholesterol, statins also have the effect of lowering this level of risk based on the inflammation.
So what you're saying here is that even if someone doesn't have primary heart disease, that the problem could be outside of the area of the heart. If they have other diseases, the body is, as we know, well connected. Inflammation in one area, such as an arthritis, may be affecting the heart.
Well, it's very indirect. People who have a high level of inflammation, it depends the type of arthritis. Degenerative joint disease doesn't give as much inflammation as rheumatoid arthritis. In fact, they did a study comparing patients who were on standard therapy for rheumatoid arthritis versus those who were given one of these new biologicals, and they found a 50% reduction in heart attacks in patients who took the new biological as compared to the old standard of methotrexate.
So here's an example of treating a disease that is not directly related to the heart. Improving that disease has beneficial effects on the heart, which brings us full circle to diet, lifestyle. Treating the whole body and improving our health in all aspects really can help reduce the risk of heart disease and heart attacks is what I'm hearing here.
And that is quite correct. Now, getting back to lifestyles, patients who are overweight or even worse, obese or morbidly obese, are more prone to get high blood pressure and diabetes. But in addition, because of the fat cells in our abdominal area, which are very bad, and I'll explain that in a minute, these patients have to lower the weight so that these fat cells do not fill with fat. Once they fill with fat, they secrete a lot of inflammatory proteins, which contribute to the apple and pear body look into having higher incidence of cardiovascular disease.
And you talk about the apple and pear. Where is the dangerous fat? We hear this on the news, we read about it. There is fat that is considered more dangerous than other. Tell me where this is.
Belly fat is the worst area. These fat cells are the cells that start when we're young, turning baby fat into regular fat. By the time we're 3 years old, the number of fat cells in our belly have been formed, and they don't get larger or smaller. They just fill with fat more or less. So there's a new procedure which actually freezes these cells and rids people of those fat cells. Of course, it's not going to help weight loss if you don't change your diet. Other fat cells outside that, the body will fill with fat, but they're not as dangerous as the fat cells in the belly.
Now, do we have data yet? Is there research yet that shows that freezing these fat cells down in the belly reduces the risk of future heart attacks, or are we still waiting to see?
I don't even know if it's being studied, but it should be if it isn't. But just on a theoretical basis, since we know the inflammatory problems related to belly fat cells will be taken away. Whether it has an impact on long-term outlooks in cardiovascular disease has not been proven.
So if a viewer out there today is watching us talk about this freezing of the fat cells and the belly fat, the first steps that they really should be taking is diet and exercise focused on reducing the size of their waist?
That's correct.
So reducing the size of the waist is the goal. That is where we're going to see a reduction in cardiac risk.
Correct. And you might want to know that people do not get fat from eating fats. They get fat from eating carbohydrates because it establishes a pattern of over-secretion of insulin, which causes a metabolic syndrome. It makes people retain their calories instead of metabolizing them, and it's stored for the future.
So this brings us back to diet a bit, and it reminds me of studies and what we were taught back in the 70s and in the 80s, that we should be on a low-fat diet. And that was what was pushed for many years, for decades, that Americans need to focus on a low-fat diet. But we ended up changing to a low-fat diet and increasing our carb intake, our carbohydrates. So did we get it wrong for all these years? Were we told to eat the wrong things back in the 70s and 80s?
Yes, we were. And it was obvious to certain people based in the mid-80s that everything was going wrong from a metabolic point of view in patients who cut their fat and ate lots of carbohydrates. And that's all about insulin.
So after changing their diet, exercising, they come to Dr. Lipton, they come to see you in the office. They're worried they could have heart disease. Tell me about these tests. What is an EKG?
An EKG means electrocardiogram. It can be also called an ECG. But because it was originally invented in Germany, the cardiogram had a K in it.
And the EKG gets done, you review it,
Right.
things look okay.
EKG is basically the electrical activity of the heart showing the direction of electrical flow, which can give us an answer to whether or not there's an abnormality in the heart muscle or primarily in the electrical system.
So you can see what we call an arrhythmia, abnormal beating of the heart. You could even tell if a heart attack has gone on or is actually happening right now.
That's correct. We can see the electricity of an old heart attack or one that's happening at the moment.
So you move on from the EKG and you tell the patient you need a stress test. Explain to us what that means, a stress test.
Okay. A lot of patients may not have any symptoms because they don't lead a life of exercise. So you want to stress their system to see if a workload will promote the signs or symptoms that mean that an artery is partially or nearly completely blocked.
Now, I went for a stress test once, and they put me on a treadmill, and they attached me to 100 different wires. How does that work?
It's quite simple. We watch the EKG and see if a certain portion of the EKG changes during exercise. Now, there are superior ways of doing stress testing now with nuclear imaging or what we call stress echocardiography, because the electrical activity of the heart changes well after the blood flow to the heart muscle has been compromised. So doing nuclear testing where a radioactive material is given to the patient will show us how much radioactivity is taken up by the heart muscle, which is dependent on blood flow to that heart muscle.
Now, based on these results, if you see a problem while someone's exercising, their EKG changes or these pictures you're talking about, they show changes, what is the next step
Well, the next step is, if the changes are very severe on the EKG, we may not finish the test and wait for the nuclear study. We'll just tell the patient, this is really so bad that we don't want to waste time. We're sending you to the hospital because we're going to arrange for you to have a coronary angiogram. Other times, the changes on the EKG are rather small and non-diagnostic, yet the perfusion that's seen on the nuclear stress portion will give us the clue that there's poor flow to the heart muscle. And then we electively can do the angiogram.
And so you mentioned this word angiogram. So for folks watching at home who may not know what this is, break that down for us. Make it very simple.
Angio means artery. So you're studying the arteries by injecting a contrast medium, or a dye, it's called, that will outline the artery, and you can see how much and to what degree these arteries are blocked up by cholesterol plaque.
And at this point, when we find these blockages or these narrowings, we call the plumber in. We call the interventional cardiologist, who is a different type of cardiologist, correct?
Right. The interventional cardiologist will do the angiogram, and if the artery is blocked and reaches certain guidelines of pressure differences between the two sides of the blockages, then they will put a stent in. A stent is basically a metal fiber straw that slips over the area where the blockage was. Now, how does it do this if the blockage is there? What they do is they inflate a balloon on the end of a catheter, and they actually crush the plaque with the high carbon dioxide pressure on the plaque, so that there's no longer a narrowing.
And the stent will sit there
and keep it there.
Incredible, incredible. So you can give somebody almost new life by opening up this blocked artery.
That's correct. Now, in certain situations, there's this culprit artery, and they will fix that right away, and we're back to the non-interventional diagnostic clinical cardiologist that I am to follow up and try to prevent progression of this disease.
So we talked about preventing getting to this point. So now we have a patient who, say, came to your office with some symptoms. You did a stress test, you did an EKG, you sent them right over for an angiogram. They had a stent put in. What do we do next? How do we prevent the next event for them?
Okay, I'm going to tell you about drugs and lifestyle. Lifestyle is the same as if you were at risk, but now you're no longer at risk. You're at risk of actually getting things worse. You have established cardiovascular disease. So the first thing we do is try to get the patient's cholesterol, specifically the LDL cholesterol, to a value of under 70. You may not know these numbers, but you probably have heard it somewhere that the cholesterol has to be lower than a certain amount. Now, this has been the threshold for many, many years for patients who have established vascular disease in any arterial bed in the body.
Meaning their legs, their arms, if they have vascular disease, problems with their arteries.
In any part of the body.
This is the goal.
It could be in the neck. It could be in the smaller cerebral brain arteries.
Magic number 70.
Number 70. But that is no longer the magic number. For patients who have not been able to get to goal because they cannot tolerate the statins or other drugs to lower it to 70, there is new medication that is injectable on an every 2-week or 4-week basis, which will lower the cholesterol even further. And recent studies have shown that over and above the statin, in patients who have not yet gotten to goal of less than 70, we can reduce further cardiovascular events by up to 25%.
So there is some magic out there. So for folks watching today, we talked about preventing the first event, signs of the first event, and there's even help after if someone actually ends up with heart disease to treat them. I want to thank you all for watching today. Thank you for your interest in our show and for watching Medcastplus. We hope that with the experts we bring here on our show, we can help educate the public about their health, prevent disease, and if you have any suggestions or want to become involved, please contact us on our website www.medcastplus.com. I'm your host, Dr. Jack Braha. Thank you for watching. We look forward to seeing you again soon.